Hi, this lecture is going to be about Medicaid and Medicare, their history, their funding, who they cover, what they cover, and where we are now. So, to give you a brief history of Medicare, Medicare was enacted in 1965, and at the time it was thought that it was going to be an interim step towards a broader goal of universal health coverage. It was patterned after private health insurance products with their traditional indemnity, which means there is a protection against loss for the insurance company. And there were two parts at the time: hospital insurance, which is Part A, and supplemental medical insurance, which are now Parts B and now D. In 2013, there were 51 million people who were covered by Medicare, and that included 42 million people who are aged 65 and older, and 8.4 million people who were considered to be permanently disabled. So, what does Medicare cover? Well, Medicare covers a number of conditions. Part A covers inpatient hospital stays, skilled nursing facility stays, some home health visits, and hospice care. Part A benefits are subject to a deductible, which is $1,288 per benefit period. That was in 2016. And beneficiaries are subject to coinsurance amounts for extended inpatient stays and hospital or skilled nursing facility stays. So that would be this hospital and inpatient, as well as physician payments. Inpatient. That's Part A. Part B is over here, the physician payments, outpatient services, preventive services, and some home health visits. Again, there's a deductible. For this, it was $166. And most of Part B benefits are subject to coinsurance of 20%. There is, however, currently no coinsurance or deductible for an annual wellness visit or preventive services that are rated A or B by the U.S. Preventive Task Force Service. So those are things like mammograms and colonoscopies, which they have been determined through research to have a significant impact on health and health outcomes, as well as cost savings. Part C is this section up here, the 27%. That's Medicare Advantage, through which beneficiaries can enroll in private health plans such as HMOs or PPOs and received Medicare-covered Part A and Part B benefits, and some Part D or prescription drug benefits. Enrollment in Medicare Advantage has grown over time, with about 17 million beneficiaries now enrolled in plans, or 31% of all Medicare beneficiaries, and that's considered a gap coverage, and I'll explain what that means in the next slide. Part D over here, so 12% of Medicare goes to Part D coverage, which are outpatient prescription drugs through private plans that contract with Medicare, including both standalone prescription drug plans and Medicare Advantage drug plans. Enrollment in Part D plans is voluntary, so not everybody participates. But the benefits help enrollees pay drug costs after the deductible is met, depending on the plan you have, that may or may not be applicable. And it offers catastrophic coverage for very high-cost drugs. Enrollees pay monthly minimum premiums and cost sharing for prescriptions, with costs varying by plan, and 5% of the total drug cost after reaching the catastrophic threshold. And there are some financial assistance available for low-income and modest-income enrollees. So as of 2015, there were 39 million people on Medicare who were also enrolled in Part D. So what does Medicare population look like? So who's covered, who isn't covered, and what conditions do they typically have? Well, Medicare coverage, if you look at the individuals, these tend to be fairly, there's older people, again, who are 65 and older. These are people who have a number of chronic or multiple chronic conditions, cognitive impairments, and limitations in their activities of daily living. The ability to cook food for themselves, get up out of a chair safely, leave their home to do shopping, etc. Many beneficiaries have modest incomes. And if you look, about 2/3 have 2 or more chronic conditions. More than 1/4 of all beneficiaries report being in fair or poor health. And just over 31% had some sort of cognitive or mental impairment. Nearly 1 in 6 beneficiaries were under the age of 65 and living with a permanent disability, and 13% were aged 85 and older. 5% of enrollees lived in a long-term facility. And in 2014, half of all Medicare individuals on Medicare had incomes below $24,150 per person and savings less than $63,000, which means that they're fairly low income overall. So we talked about what Medicare covers, but there's also a number of things that it does not cover. It's important to note that Medicare still has significant gaps in coverage and relatively high cost sharing requirements, which requires beneficiaries to absorb some pretty high costs. While Medicare covers basic benefits and now helps pay for prescription drugs, it does not pay for long-term care. Medicare has limited skilled nursing facility benefits for up to 100 days and home health benefits, but it does not pay for ongoing care with long-term care needs, either in nursing homes, assisted facilities, or at home. Medicare also does not pay for dental care, which can be quite expensive, and does not cover hearing aids or glasses, which, if you think about people as they age, almost everybody will need glasses at some point as you age. That's just a function of the breakdown of your eyes, and many older adults need hearing aids as well. Further, Medicare has relatively high cost sharing when the deductibles and other cost sharing are considered. And unlike typical large employer plans, Medicare's drug benefit Part D has a coverage gap. When the beneficiaries have to pay 25% of the cost of drugs in the gap, and that's not scheduled to close under the ACA until 2020, unless the ACA is repealed, in which case we don't really know what's going to happen to that coverage. Medicare also does not have a cap on catastrophic out-of-pocket expenses for cover benefits, so you can just keep paying and paying and paying. In light of Medicare's benefit gaps, cost-sharing requirements, and lack of annual out-of-pocket spending, most beneficiaries need and have some sort of supplemental coverage to help fill in the gaps and cover the cost-sharing requirements. So Medigap policies, also called Medicare supplemental insurance, provide coverage for about 1 in 5 people in traditional Medicare as of 2011. These policies, which are typically sold by private insurance companies, fully or partially cover Medicare Part A and Part B cost sharing, including deductibles, co-payments, and co-insurance. However, access to supplemental coverage does vary by income. And so, as you can see from this figure, individuals with higher incomes tend to be able to either maintain their employer, so they're either retiring with benefits or they may be 65 and older and have both benefits, as compared to lower income individuals. So if you're a low income individual, you most likely have Medicaid. Very few have employer provided insurance. About 9% are able to purchase their own, and about 14% have either other public or private, meaning most likely in those cases they're eligible not only for Medicare but Medicaid as well. Medicare's beneficiaries spent on average about $5,000 out of pocket for their own healthcare spending, and nearly half of that spending were for premiums and other types of supplemental insurance, and the rest went for medical care and long-term care services. Most of the spending that comes for out-of-pocket per capita on average is for long-term care facilities, followed by providers, supplements, supplies, drugs, etc. And out-of-pocket spending rises with age. So obviously, not surprisingly, the older you get, the more medical conditions you have, the higher your cost share, therefore, the more you spend, and is often higher for women than men. Medicare beneficiaries who have poor health, not surprisingly, spend more than those who rate themselves in better health. And individuals with low income actually have greater out-of-pocket spending than individuals with higher income. Why is that? Well, because they're less likely to have employer-provided health insurance, and therefore those gaps in coverage have to be made up for with out-of-pocket spending. So that, in a nutshell, is Medicare. What's Medicaid? Well, let's at least start to think about what the public opinion is. And when we hear the terms Medicare, people who are aware that that is for older individuals and individuals with disability tend to refer to those as individuals who are Medicare beneficiaries. Medicaid, however, is geared towards helping individuals who are low income. And when you talk about it, when people talk, listen, if you're listening to the news, if you're reading news articles, Medicare, people on Medicare are referred to as beneficiaries versus Medicaid, which tend to be seen as recipients. And there's a reason why that terminology is different. There's a reason how we think of that and what the public opinion is. And so, if you go into the news, or better yet, go into the comments section of any article online that's about healthcare and Medicaid, and you'll find that the public opinion, who are they? Oh, those are those lazy people, right? They're lazy, they're good for nothing, they don't have jobs, they don't want to work. What are they getting? Well, they're getting something that they don't deserve, is the public opinion typically. And they're getting far too much. They're a drain on the system, and they're taking more than they're giving, right? Those are the quote-unquote takers. So, recognizing that this is public opinion, let's see whether or not those things are actually, in fact, true. So, Medicaid was also enacted in 1965 and part of Lyndon Johnson's Great Society programs. It had, at the time, there was a strong Democratic majority in Congress, and both Medicare and Medicaid were designed as categorical eligibility programs rather than universal programs. Again, that idea of incremental change. So we'll start by covering these people with the goal of expanding them over time. Now, that was 1965. Nothing was expanded in Medicaid until 1997 with the CHIP program for children's health, and 2010 with the enaction of the Affordable Care Act. And Medicaid was actually added as a rider to the Medicare bill. It was considered quote-unquote sleeper legislation. Cost estimates were small, and most people weren't paying attention to that part of the bill because Medicare was really the big part. And Medicaid was originally envisioned as a small program. It was supposed to help out moms and kids. Well, Medicaid today covers about 70 million Americans. That's Medicaid plus CHIP, when you add in the children's health, adds another 2 million. It is means tested with categorical eligibility. So, currently, or pre-ACA, it was low-income children, pregnant women, parents, and now non-elderly adults now post-ACA, low-income elderly, and individuals with disabilities of any age. And unlike Medicare, there's actually minimal cost sharing with Medicaid. Also, unlike Medicare, Medicaid provides long-term care and health coverage. So for older adults who are eligible for Medicare, who need long-term care, they're often dual enrolled and dual eligible for Medicaid and Medicare. Medicaid picks up the long-term care part. And it provides, again, low-cost health insurance for about 32 million children, 18.6 non-elderly adults, and 16 million elderly and persons with disabilities. And so that includes 6 million Medicare beneficiaries who are considered dual enrollees and use this as their supplemental insurance when they fall into that gap. Pre-ACA, being poor, unlike the common misperception, was not enough to qualify for Medicaid. You had to be low income and older, blind or disabled, and for adults, a single parent with dependent children. So if you were married, or if you were a single adult without children, or children living in your home, you were not eligible at all. The program has been routinely criticized for its cumbersome enrollment process, and there have been efforts to simplify that. And state waiver options were introduced in the 1990s in order to expand the eligibility. And so if you look at this, pre-ACA, most low-income adults did not qualify for Medicaid because Medicaid eligibility for parents, even though they were eligible, was very limited and well below the state poverty level in most states. And federal law excluded adults without dependent children from the program, and these left many poor and low-income adults uninsured. When we're talking about the federal poverty level, I just want you to see what it looks like. So, for example, if you're a single individual with an income of $20,000, the 2016 poverty guideline for a one-person household is 11,000. I'm sorry, these are the 2017, but 2016 were 11,880. So, if you take your $20,000 and you divide it by your 11,880, that gives you 1.68. That means you're at 168% of the federal poverty guidelines. So that's how they determine your eligibility. With the ACA, there was expanded coverage. So for the first time, non-elderly adults up to 138% of the federal poverty level, or $16,394 annual income for a single adult, would now be eligible for the Affordable Care Act. And they expanded federal funding to cover that expansion. It also streamlined eligibility and enrollment and gave states options for funding and delivery system innovation. So if states could come up with a better plan to help fund and operate the system, then they would be given those options and provided funding to do so. It also expanded options for community-based long-term care, with the goal of having people stay in their home as much as possible, so that improved home health care. However, the Supreme Court ruled that the expansion is optional for states as of 2017. And as a result, 32 states and the District of Columbia and Washington, D.C. expanded Medicaid, and 19 chose not to. So under Medicaid, who's covered? Well, it covers nearly half of all births in the United States. It covers 40% of all children and 75% of poor children. Reflecting more restrictive state eligibility rules for adults, Medicaid covers 40% of poor non-elderly adults, and 60% of children with disabilities, and 30% of non-elderly adults with disabilities, including individuals with severe physical disabilities, developmental disabilities such as autism and traumatic brain injury, and serious mental illness, Alzheimer's, and other chronic conditions. Again, states can opt out to provide Medicaid for children with significant disabilities and higher income families to fill in gaps in private health insurance. They cannot opt out. They can opt to provide Medicaid for children with significant disabilities who are also in higher income families, because there are still gaps in private health insurance. Medicaid also assists 1 in 5 Medicare beneficiaries with their Medicare premiums and cost sharing, and for things that aren't covered by Medicare, like long-term care, dental care, and vision. More than 42% of spending for Medicaid is on dual eligibles, those people who are eligible for both Medicaid and Medicare. And unlike the public opinion that these are lazy individuals who just need to get a job, 75% of Medicaid enrollees are members of working families. And it's also important to note that Medicaid covers many, but not all, poor Americans. In non-expansion states, 2.6 million adults with incomes below 100% of the federal poverty level fall into the coverage gap because their income exceeds the state cutoff for Medicaid, but is too low to qualify for the subsidies for private coverage in the ACA marketplace. Nationally, 46% of uninsured adults in the coverage gap are white non-Hispanics. 18% are Hispanic and 31% are Black. However, race and ethnicity of people in the coverage gap also reflects the racial and ethnic composition of states moving forward with Medicaid expansion and states planning not to expand. Several states that have large Black populations, Florida, Georgia, Texas, have not expanded Medicaid under the ACA. And as a result, Black Americans account for a slightly higher share of people in the coverage gap compared to the total poor adult population. And racial and ethnic characteristics of the population in the coverage gap vary widely by state, generally mirroring the underlying characteristics of the state population. They also vary by age and by health status. So the two most common groups, if you look, individuals in the gap are about 35 to 54. So these are older adults. They're not the young adults, but who are not yet eligible for Medicare. The work status of people in the coverage gap indicates that there are limited coverage options for people in this situation. 62% of people in the coverage gap are in the family with a worker, and half of those are working themselves. While workers could potentially have an offer of coverage through their employer, nearly half of workers in the coverage gap, about 47%, work for small firms that are not subject to ACA penalties for not offering coverage. Further, many firms do not offer coverage for part-time workers. And a majority of workers in the coverage gap also work in industries with historically low insurance rate, such as agriculture and service industries. So again, if you look at people who are in that gap, most of them are workers, either full or part-time. Most have family members, if they're the child or a dependent of somebody who is working. And about a third are not currently working. So who could be covered if every state expanded? Well, all 2.6 million adults who are currently in the coverage gap would gain Medicaid eligibility. In addition, 1.4 million adults who are currently eligible for the marketplace, those with incomes between 100 and 38% of poverty, would also gain Medicaid eligibility. Though most of these adults are eligible for tax credits to purchase marketplace coverage, Medicaid coverage could provide lower premiums and cost sharing than they would have to face under the marketplace coverage. The public perception of Medicaid tends to be that people who are too lazy to work are running up the costs and taking resources that they don't deserve. The truth is, however, the majority of Medicaid enrollees are children who account in 2005, who accounted for about 18% of Medicaid expenditures. The majority of Medicaid expenditures were accounted for by the elderly and individuals with disabilities, or about 70% of total spending. Very little of that funding came for the 26% who were enrolled, who were adults, who are not elderly, not disabled. So about 12% of that spending. And as of 2011, that hasn't changed significantly. Children still made up about half of Medicaid enrollees and about 21% of expenditures. Adults increased, so non-elderly adults, non-disabled adults, increased to 27%, but still only made about 15% of the spending. Majority of spending, again, about 63% as of 2011, was made up by individuals with disabilities and the elderly. And so, as we said, since that 3/4 of Medicaid enrollees come from working families, these aren't by and large people who are, quote, too lazy and refuse to work, despite the stereotypes we tend to hold. This is the map of uninsured rates among children by state for 2005 and 2006. So the white states were people who had children less than 8% unenrolled. 17 states and DC had between 8 and 11% uninsured children. And 18 states had uninsurance rates for children of over 12%, and that does include New Jersey. With the expansion of CHIP and Medicaid, that has changed. The map has changed quite a bit. And so you can see here, for example, New Jersey, which was once amongst the highest for uninsured rates of children aged 0 to 18, is now down to between 2 and 3%. And not surprisingly, the states that did not expand Medicaid coverage still have amongst the highest, 9 to 13% uninsured rates for children. And what does that mean? That means those children are probably not getting well child visits, they're not getting preventive services, they may not be vaccinated, which has a significant impact on their health as children, and as we'll learn later, will continue to have impact on their health throughout the rest of their lives. And so, as noted in the previous lecture, if the American Health Care Act, or AHCA, becomes law, the House bill will cap federal funding for more than 74 million low-income children, adults, seniors, and people with disabilities who are currently covered with Medicaid. It would also phase out the enhanced federal funding for the 11 million adults who are newly eligible under the ACA Medicaid expansion. And by 2026, it's estimated that 14 million fewer people would be covered by Medicaid relative to the number expected under current law, and the number of insured people will increase by 21 million, reaching an estimated 52 million by 2026. Prior to the ACA, that number was somewhere between 45 and 48 million. So that's a significant number of people who would go back to having no health insurance, which, recall back, limits your access to preventive and primary care services and creates individuals who are less healthy and who tend to go into the health system at much later stages on that pyramid. So it's secondary and tertiary care, which are the most expensive care. So there is an expense to having people uninsured. It does not bring down the rates for national spending. If anything, it actually increases it. And so where do we go now in terms of Medicaid reform? And so the question that I'm asking for you all to do in the discussion section is, what do you think should happen? We have this situation that is happening right now where we have the Affordable Care Act. Some states have expanded, some others haven't. Should we amend that? Should we figure out a way to make sure that it's expanded in all states? Should we do away with it completely? Should we follow the American Health Care Act and roll back Medicaid reform? What do you think we should do? So based on the readings, based on all of the lectures that you've heard thus far, what are your opinions on where we should go now? And when you've formed that opinion, make sure you bring that opinion with you and be politically engaged and active, because your voice matters.